I'd like to introduce the first speaker, Dr. Sven Francque. He's a professor of hepatology at the University Hospital and University of Antwerp.
Thank you, Bart. Thank you for the kind introduction, and thank you also for to you and the scientific committee for the kind invitation. This is always a great meeting, and as a hepatologist, I always learn a lot about metabolism. So that's very much appreciated. Thank you. Now, I don't think I need to introduce the PPARs to this esteemed audience, but this cartoon is just to remind you about the complexity of the PPAR field, with the three isotopes, the alpha, the delta, and the gamma, being differentially expressed about a wide range of organs and within organs in different cell types, also in the liver. This is the detail of this, has been the detail of this review, but there are differences according to whether it's hepatocytes or inflammatory cells or stellate cells or endothelial cells. A few highlights because it's relevant for the rest of the talk, but it's a real oversimplification of the complexity of this field. But if we look in hepatocytes, for example, then we know that at least in normal circumstances, PPAR alpha is the dominant PPAR that is expressed, but it's also expressed in other tissues. PPAR gamma is the main PPAR expressed in the adipose tissue, but it's also expressed in stellate cells, at least in the quiescent state. And PPAR delta is also expressed in stellate cells, but as you know, also in pancreatic beta cells and in muscle cells. But these are just a few highlights that are relevant for the rest of the talk, as I said. Now, this is very complicated, and all these effects are different according to cell types and also ligand dependent, different functions according to different cell types and ligands. But not only this is complicated, also the pathophysiology of NASH is complicated, as you can see from this cartoon. And again, I will of course not go into the details, but in terms of pathophysiology, there is a lot going on inside the liver, different pathways that are altered in the hepatocytes, but also in the stellate cells, in the inflammatory cells, in the endothelial cells. And this is, as we also learned yesterday and today, of course, not an isolated liver disease. Much of what is happening inside the liver, and of course, factors of susceptibility inside the liver play a role, but much of this disease is also driven by factors that happen outside the liver, and especially the adipose tissue is an important driver of this disease, not isolatedly, of course, also pancreas is playing a role, the muscle is playing a role, as we learned. So it's important to realize that this liver disease is at least in part driven by what happens outside the liver. This has also been nicely reviewed by the chair of this group, Amalia Gastadelli, showing or reviewing that the dysfunctional adipose tissue, not just by releasing free fatty acids, but also because of the impact on adipokines and on inflammatory cells and inflammatory mediators, has a tremendous impact on the liver via the adipose tissue liver connection via the portal vein, of course, anatomically. Now, if we simplify this a little bit, progressive liver disease will happen when there is, of course, an imbalance between damage and repair. It's not static. There's always that repair mechanisms that try to restore the normal physiological conditions. So you will have progressive liver disease when you have an imbalance here. Now, fibrogenesis, of course, does not come out of the blue. There are always factors that drive that fibrogenesis. And so the upstream driver is, of course, the damage and the inflammation to the liver tissue. And that damage and inflammation on its turn is driven by upstream metabolic drivers. And all these mechanisms, of course, happen inside the liver. But as I showed you in the previous, more complicated cartoon, much of these upstream drivers are also coming from outside the liver. And this very simplistic scheme is important also to understand some of the successes and failures that we have seen in pharmacological treatment for this condition. Now, a first approach, because if you have the complexity of the PPAR cartoon that I showed you, and you overlay that to the cartoon of the complexity of the NAFLD pathophysiology, you can easily understand that, at least from a conceptual point of view, those PPARs are potentially very interesting targets to explain the pathophysiology of the disease, at least in part, and hence also to target them for therapy of this disease. Our first approach has been to target PPAR gamma with the TZDs. And the most data we have are with pioglitazone, which of course, as you know, is not a pure PPAR gamma, also a little bit of PPAR alpha. And to make a long story short, in terms of effect on liver histology, which is in terms of pharmacological development an important endpoint that we try to achieve for success of pharmacological therapy, is getting rid of the steatohepatitis, so the resolution of the steatohepatitis. And you see here in this trial from Ken Kusi's group from a few years ago, that clearly in terms of resolution of steatohepatitis, so having an impact on the steatohepatitis, this drug was clearly positive compared to placebo. There's also, as you can see, a clear decrease in liver fat content, and of course, as you would expect with this drug, an improvement in metabolic parameters, the insulin sensitivity, not only in the adipose tissue, but also in the liver and the muscle improved with this drug, along with the improvements in liver histology. If you then look at what is from hepatology perspective, an important other target of therapy or efficacy endpoint that we want to achieve, that is the regression of fibrosis. Now you can discuss whether this really needs to be regression, but anyhow, this is an important endpoint in clinical trials, and pioglitazone did not achieve that endpoint. So a clear effect on resolution of steatohepatitis, but it did not go along with a clear effect on regression of fibrosis, at least one stage, according to the classification system that we use. Other trials have confirmed it. This is the famous PIVENS trial that has been led by Arun Sanyal, comparing placebo to vitamin E and pioglitazone. There were efficacy results for vitamin E, but as you can see, also for pioglitazone. And again, it was with a clear effect on the activity of the disease, on the steatohepatitis component, but not on fibrosis regression. This was substantiated by effects on liver enzymes, which is also something that we always look into, of course, if we have patients with NASH treated in a clinical trial. You see the improvement in insulin sensitivity again, and also then something that I will come back to later on. What we see with PPAR gamma drugs is, of course, that despite the liver is going better and metabolic parameters are going better, that there is some increase in body weight, which is, of course, always a concern, as we have just been telling all these 2 days that we need to reduce body weight to improve the liver. Now, another trial has then further confirmed what I just showed you, and this was building further on the PIVENS trial, comparing placebo to vitamin E plus then the combination of vitamin E and pioglitazone, so not pioglitazone alone. And again, you get the same picture. There is an improvement in terms of resolution of steatohepatitis, which some higher efficacy in the combination of both compared to vitamin E alone, but again, no efficacy in terms of regression of fibrosis. So a consistent story with pioglitazone on these histological endpoints. Now, do you call this a success or a failure? That's of course an important discussion point, because what in the end, at least from a hepatological perspective, because we know, of course, that cardiovascular disease is the most important reason for morbidity and mortality in these patients. But from a hepatological perspective, we are, of course, looking into patients going to cirrhosis and the complications of cirrhosis and going to hepatocellular carcinoma. Now, you can say, okay, we need regression of fibrosis, but just halting progression towards a more severe fibrosis stage could already be considered enough, because you're halting the progression of the disease and the patient will not go to the clinical more severe endpoint. And also, as I said previously, it's not just about the fibrosis. The steatohepatitis, the damage and inflammation in the liver, is really what drives this disease. And so if you have a clear impact on the steatohepatitis, that's already very important, because you suppress the engine that drives the disease, and on the long run, that will translate into improvement of fibrosis. So is it a success or is it a failure? If you really want to have the fibrosis regressed, probably this is not powerful enough, and you need some more direct anti-fibrotic effects to really have regression of fibrosis. So that brings me a little bit back to this scheme. Probably the result here is not what you would expect if you really want to regress fibrosis, because you're mainly tackling the extrahepatic drivers, but you leave more or less the intrahepatic drivers untouched. Not completely, as I said, there is also some people gamma expression in stellate cells, which is of course relevant, but clearly not powerful enough to have, at least in the time frame of the studies that have been conducted, a regression of fibrosis. But there is halting of progression of disease for sure. And of course, we need to take into account the limitations of the way we currently assess efficacy of treatment in NASH clinical trials. And of course, we need to take into account, as for every drug, the safety and tolerability profile. That was the PPAR gamma approach. Then PPAR alpha. What we know from PPAR alpha expression, at least in NASH, is that it's clearly decreased with more severe disease, which does of course not mean that one is causally related to the other. But what we also observed in patients is that on the long run, if they improve their steatohepatitis, there is also an improvement in their PPAR alpha expression. So at least the two are correlated also in terms of evolution over time. So targeting PPAR alpha could be a good solution. There are not so many trials with PPAR alpha agonists, monoagonists. The most recent one is the PIMA-FIBRID trial, showing no clear effect in terms of reduction of liver fat. There was some reduction in liver enzymes and some reduction also in liver stiffness, as you can see on the lower part of this cartoon. But in terms of liver fat, there was no improvement. No histology data, but as I said, some improvement in some, but not all, of the liver biochemistry. So again, the question is whether this will be enough to translate really in NASH resolution and fibrosis regression. I'm not going to discuss in detail the third mono-PPAR approach that you can consider, the PPAR delta approach, which has been tempted with seladelpar. Now there has been a stop in the trial at a certain time point because there was some suspicion of DILI based on examination of some of the end of treatment liver biopsies. Now, a thorough examination of these biopsies, baseline and follow-up, did not confirm that, so that was waived. But despite that, at least in NASH, the trial was still on hold, and the development in NASH has not been pursued further. So that's let's say the more mono-PPAR approach. Then dual agonist is an approach that you could envision to improve the efficacy. Elafibranor is a PPAR alpha delta compound that has been studied with the hepatic tropism, so mainly active intrahepatically. And again, as with the other compounds that I did not go into the details of the preclinical data, but for any of these compounds, we really had a bunch of preclinical data suggesting that this kind of approaches could be beneficial. And so also for elafibranor, there was a huge amount of preclinical data suggesting that it could be an efficacious drug to treat NASH. Now, the phase 2 data with 1 year of treatment showed that if you use the definition of NASH resolution as we currently use it, that you have a significant effect of the drug compared to placebo, at least for the 120 milligram. As you can see, the effect size was not very large, but it was clinically significant, and the effect size was bigger when you restricted the analysis to patients with more severe disease. In terms of fibrosis regression overall, there was no improvement, but if you look into patients that had resolution of NASH or who improved their NASH, in these patients, there was also improvement of fibrosis, again illustrating how closely steatohepatitis and fibrosis are linked. This drug, based on these phase 2 results, went into a phase 3 trial. I'm not going to detail the designs of phase 3 trials, but it's important that in the current design of these trials, at a certain time point of treatment, we have a liver biopsy again to have a histological assessment of the efficacy of the drug. In this trial, it was after 72 weeks of treatment. And to make a long story short, in terms of resolution of NASH without worsening of fibrosis, there was probably some trend, but it was not statistically significant. And when looking again into fibrosis regression, there was no effect of the drug. Now again, if you look a little bit more into the details, you see that if you look into the parameters of the activity of the disease, you see a clear trend, just not significant, for an effect on the most important histological markers of disease activity, being lobular inflammation and ballooning. So this is consistent with the phase 2 data, but not powerful enough to hit a significance on that global population of patients. And probably the reason is, again, to be found in this simplified cartoon, because mainly this drug tackles the intrahepatic mechanisms of the disease, but has little or no effect on the extrahepatic mechanisms, which is probably one of the important reasons why in the complexity of the human body, this did not hit the desired endpoint. And of course, as I said, there is a bunch of preclinical data that were very supportive of this, and also for other drugs. And one of the reasons why probably it does not always translate into results in patients, it's of course the complexity of the human metabolism compared to rodent metabolism, and also the interspecies differences, which are clearly there for PPAR alpha, with less PPAR alpha activity in human livers, and also no induction of these in several circumstances, which is different compared to rodents. For PPAR gamma, it looks like it's more conserved across species, but even there you see interspecies differences. So we really need to take that into account, and also all aspects of ligand-specific interactions to understand why some of the promises in preclinical data did not translate into the human condition, and should be considered in this case a failure. Another dual PPAR approach is the saroglitazar with PPAR alpha and gamma approach. We do not have data in randomized controlled trials on histology yet. What we have to date is data on non-invasive parameters in a 60-week treatment period, as you can see here, with several arms in terms of doses compared to placebo. There's a clear effect on liver enzymes, as you can see here, dose-dependent effect. So suggestive, at least, that something is improving at the liver level. And at least for the highest dose of 4 milligrams, there is also a clear reduction in liver fat, here expressed as the number of people that reduce their liver fat content by 10%, 20%, or 30% or more. There's an improvement in lipid profile, which is, of course, also important in this population because of the cardiovascular risk. And in terms of metabolism, there is what you would expect, because it's a PPAR gamma, a drug with a PPAR gamma activity, besides a PPAR alpha activity, is the improvement in adipose tissue function, reflected by an increase in adiponectin. In this trial, they did not observe significant weight gain, although numerically there is some weight gain on the active treatment arms compared to placebo, but it did not reach statistical significance. But just to remind that this was 16 weeks of treatment. And also in terms of improving glycemic control, what you also would expect with this mode of action of the drug, there was some improvement in insulin sensitivity, calculated here as the HOMA index, with all the limitations of that. There were no changes in HbA1c or in fasting plasma glucose, but again, it was only 16 weeks of treatment. So that's a drug that we will further investigate in trials with histological endpoints, but these data are not available yet. So mono agonist, dual agonist, and then of course the next step is targeting 3 PPAR type isotypes at the same time with the pan-PPAR, and that has also been tested with lanifibranor in a trial that the treatment period lasted for 24 weeks, which is a rather short period of time. And in terms of again, histological endpoints, you see that there is a clear dose-dependent effect on NASH resolution, also on fibrosis regression, which is important because this is the first drug to report both on NASH resolution and fibrosis regression significant results, but also, and that's of course what you would like to see, you want to see those two things happening in the same patients. So the combined endpoint of NASH resolution and fibrosis regression in the same patient was also dose-dependently and highly significantly met by this pan-PPAR approach, with also improvements in liver enzymes, as you would expect. I'm not going into the details. There's also improvement in glycemic control and in the lipid profile. The side effects were gastrointestinal symptoms and headache mainly. And again, there is, of course, what you would expect, the aspect of weight gain that we need to have a close look at. And also in this trial with the drug that has also PPAR gamma activity, we saw some weight gain, on average 2.4 and 2.7 according to the dose, with some plateau at the end of the treatment. So to remind you, it was a 6-month treatment. I think the weight gain deserves a little bit of attention, and again, I can rely on work of Amalia Gastadelli to elaborate a little bit on this. This is a recent study that she published where she looked in detail at the body composition of a group of patients that had lifestyle intervention to lose weight. And if we first then look at those that were successful in that and reduced their body weight, if we then look at visceral fat on the lower left side, the subcutaneous fat and the liver fat, what you can see is that these patients that lost weight, they lost liver fat. And in terms of fat content, the visceral fat did not change. It was mainly subcutaneous fat that these patients lost. The patients that were not successful, they gained weight. And where was the weight going? As we would expect, they also increased their liver fat, which is in line with what is also shown in the previous talks. And both in terms of visceral fat and subcutaneous fat, the amounts increased. Now, she compared it also with a group of patients treated with pioglitazone, again, the PPAR gamma compound. And again, in line with previous data, of course, on average, these patients gained weight. But in contrast to this group, they had a reduction in liver fat comparable to those that lost weight on lifestyle management. And the visceral fat in these patients went down. It did not go up, it went down. So all the fat clearly went to subcutaneous adipose tissue that indeed increased. And this is in line, of course, with also what we know of the adiponectin levels. So you have an improvement in the function of the adipose tissue, which is then allowed to do what it should do in physiological circumstances and accumulate neutral lipids as a calorie reserve. And so the ectopic fat depositions, they're shrinking because the fat can go where it should go, and it's not accumulated ectopically. And that is what explains why in these patients, despite the fact that they gain a little bit of weight, they go better from a metabolic point of view and also from a liver fat content point of view, and also from a steatohepatitis point of view. Now, finally, a short word, because if we look at it again from a hepatological perspective, we are, of course, very concerned about the evolution towards end-stage liver disease and portal hypertension. Do we have data there on this class of drugs? Well, very little. This is a study from Jordi Gracia-Sanchez from Barcelona, mainly preclinical work. In patients, they looked at the PPAR expression, and again, they confirmed reduced PPAR alpha expression in patients with NASH cirrhosis. So it's nice to see these results confirmed. But in terms then of the preclinical work they did, and I just pick out one effect. So the animals were treated with, again, with the pan-PPAR agonist, lanifibranor. And as you can see, there was a clear improvement both in the structure of the endothelium and also in the function. Here, this is the relaxation on the administration of acetylcholine, which is preserved in the animals on lanifibranor and which is hampered in animals that have steatohepatitis, and also other morphological markers like immunohistochemistry for VE cadherin clearly shows you the improvement in both structure and function of the endothelium. And this also translates into an improvement of the liver perfusion. So the liver intrahepatic vascular resistance goes down, which translates into a reduction of the portal pressure and an increase in the portal flow. So this is preclinical data, but interesting and promising in terms of portal hypertension, but we do not have so far portal hypertension or the cirrhotic trial drugs in these patients. So in conclusion, PPARs, of course, as we know, they are key regulators of metabolism and inflammation and fibrogenesis. And as such, they play an important role in the pathophysiology of NASH. So if we have agonists for these nuclear receptors, of course, we potentially tackle key features of the pathophysiology of NASH. We should take into account that complex differential organ-specific expression and function of those three isotypes, which most probably is key to understand also the different effects of mono-dual and pan-PPAR agonists. And then from a hepatological perspective, I think also the effect on the vascular lesions and on portal hypertension is something that we should explore in detail to explore the further potential of these drugs in the treatment of NASH. Thank you.
Thank you very much, Sven, for this overview in the PPAR field. I see that Roy raises his hand and has a question. So, Roy.
Thanks very much. Lovely talk, Sven. Really interesting and complex area. Some years ago, we followed up on the observations of pioglitazone, which I think Amelia and later ourselves demonstrated reduced liver fat very significantly. We're combining it with our clinical observations of several years ago that unlike other PPAR alpha agonists, bezafibrate decreased fasting blood glucose in diabetes and improved HbA1c. So we thought we might get a better effect by using the two agents combined. But in fact, when we treated people with type 2 diabetes with bezafibrate and pioglitazone, the effect on liver fat change was obliterated. There was absolutely no change in liver fat. There was still a change in subcutaneous fat. The subcutaneous fat volume rose significantly, but there was an obliteration of the effect on the liver. Now, obviously, the newer combined gamma alpha agents have not survived testing. But I just wonder if you have any mechanistic insights into that observation we published a long time ago, 2009, I believe.
It's an excellent question, of course, and it's intriguing. I do not have a clear explanation for that. Of course, the big difficulty is that these different mechanisms are so closely related, and it's not just about what a given PPAR isotype does in a specific cell, but it's sometimes also highly ligand dependent, and with different ligands you can have different effects, and that makes it complicated and also very difficult to predict what in a given combination will be. But that's as far as I can get now to mechanistically explain that observation.
Yeah, it's a really a strange combination, Roy, because as you probably know, pioglitazone is major gamma activity, but some alpha. Jorge Plutsky showed that at least in preclinical models, and if you compare pio with rosiglitazone, you see lipid effects that are similar to an alpha agonist. But bezafibrate has been shown to have a triple agonistic activity, so it also activates beta and gamma. So if you combine two drugs together, it's kind of acting on the same target. You probably get some interference, and then it depends on the affinity for the target, and also, of course, the biodistribution and pharmacokinetics. So it's really complicated to combine these two drugs. But why you don't see the liver fat lowering, that's quite surprising if you see it on the single drugs. But I know Vlad, who's our next speaker, also did a study with the pure gamma agonist rosiglitazone, and Vlad, if I remember well, the only effect you see with this pure agonist is a decrease in liver fat. There was no improvement of NASH. So Sven, that I would like to ask you, because it's a complicated field. Each drug is different, clearly. So the idea is, would you agree that the idea now is that you really need to hit several PPARs in different tissues to have a beneficial effect? And then if you get that on NASH, with respect to fibrosis, I mean, the data you presented were less exciting. So do you think lanifibranor will have the promise to hit the fibrosis effect that you wish as a hepatologist to achieve in your patients?
I think I will answer your question in two levels. As I mentioned during my talk, of course, it depends on what you really want to achieve. Fibrosis regression is one of the endpoints that are agreed upon by the regulatory authorities, but of course, if the clinical relevance of such a stringent endpoint is something that you can question. It's of course also a very crude classification ranging from 0 to 4, and it's also not linear. It has to do with not only with quantity but also with the pattern. So but of course, if you have such a high barrier endpoint, if you hit it, you have probably a quite powerful impact on fibrosis, which is less clear when you do not hit the endpoint. As you have seen with, for example, with pioglitazone, but also what we have seen with semaglutide. If you take the overall picture about fibrosis progressors being stable or regressors, you see some effect on fibrosis, but not strong enough to translate into real regression of fibrosis. So if we stick to that endpoint, I think indeed what these data and other data have shown is that if you are not tackling several mechanisms at the same time, intrahepatic and extrahepatic, the drivers of the disease and some more downstream mechanisms, if you just hit one of those, you're probably not powerful enough to translate into fibrosis regression. So I think indeed you need to have an impact on these different drivers inside and outside the liver to hit the target of fibrosis regression in a relatively short time frame. Yeah.
Amalia.
Yes, I have a question about visceral fat because, for example, in the study on pioglitazone that you showed that was published on Liver International, we have demonstrated that the decrease in visceral fat was really strongly related to the beneficial effect of pioglitazone. So, and of course, everybody, I mean, yesterday Pano and today Keith have shown, the impact on adipose tissue insulin resistance. But we know that the visceral fat is the minimum component of a total lipids, but they are released into the portal vein. So this is very important. So I was thinking, I wanted to ask you, and maybe Roy also has a comment, because he also showed that there was a decrease in the waist and in the visceral fat in his trial. How much is what is the importance of visceral fat in the development and also in the resolution of fibrosis, in your opinion? And these drugs, the drugs that are impacting on visceral fat, will be the one that will be most successful?
Anyhow, I think it's in this disease, it's of course not just about the visceral adipose tissue, but for sure it has been clearly shown that the NASH is more severe in patients that have more visceral fat across BMI categories. And there are also quite some interesting mechanistic data that help you understand why that can be the case. And what is also shown, especially also with the lanifibranor data, for example, and also with other ones, that there is some correlation between the response you see in histology and the improvement in adiponectin levels, for example. So clearly that is one of the important drivers of the disease. Of course, it's not the only one. There will be several other factors that play a role. What also plays a role is of course the way the liver is capable to deal with all the damaging and inflammatory factors that come from outside the liver, and most notably from the adipose tissue. And in some patients, even if they have visceral fat that is dysfunctional, it will not translate in so much liver disease because there are better weapons in their liver to cope with that. So it's for sure a combination of these different factors. But anyhow, I think it's not the factor, but it's one of the most important drivers of this disease. And if you really want to tackle this disease, you need to have a substantial impact on that. And if that's not the case, you will probably have an improvement in a limited number of patients, but you will not be able to improve the bulk of patients in whom this is really one of the most important drivers. I don't know if that answers your question.
And if I could maybe comment there, Amelia, nice question. I think from a metabolic point of view, visceral fat has no direct metabolic effect. I'm quite satisfied by a number of studies, including yours, that really visceral fat is a hugely useful marker for everything we know is bad. But for instance, in our Retune study that I presented, we take these people who look slim, we get them to lose weight, their liver fat goes to normal. The visceral fat is still elevated compared to the controls. These are people who store a lot of fat, and yet metabolically they're normal. So I think once again, we may see perhaps a divergence between liver effects and metabolic effects, because I would regard visceral fat as an enormously useful indicator. It can be used in clinical practice very easily by using a waist measurement. And from the point of view of what affects the metabolism of the liver, it's the fat inside the liver that's calling the shots.
Okay, thank you very much, Sven.